Halo Sobat Sehat, apa kabar hari ini? Semoga sehat dan semangat terus walaupun kita masih berada di masa pandemi ini ya. Selamat datang di acara kelas sehat Dr. Mike bersama saya Mikael Yosia yang akan memandu program ini selama 1 jam ke depan. Di program ini kita akan berbincang langsung dengan narasumber yang memiliki keahlian di bidang kesehatan atau dengan orang-orang yang memiliki pengalaman seru yang bisa menginspirasi banyak orang. Oke, jadi tema kita hari ini adalah vaginismus nih. Sebuah gangguan otot yang terjadi pada vagina sehingga membuat penderitanya sulit untuk melakukan penetrasi seksual. Kondisi ini membuat banyak penderitanya mengalami stigma dan trauma. Kita akan membandingkan sekarang dengan penanganan penyakit ini di Amerika Serikat. Apakah ada terobosan baru dalam penanganannya yang bisa kita terapkan di Indonesia? Kita simak bersama ya. Dr. Amanda, thank you so much for joining us today. It's been a pleasure having you. We know you're very busy, but thank you for taking the time to join us in this show. Without further ado, I'll give the time and space to you to give us your thoughts on vaginismus treatment in USA and progress that is happening in US currently. Please.
Absolutely. Thank you so much for having me. And certainly vaginismus is a diagnosis that I think is culturally managed differently in different places, in different countries, but we're trying to find some common ground. And one of the things that I want to highlight is that there's a lot of different modalities of treatment for vaginismus, and it often involves a lot of different types of healthcare providers, particularly here in the United States. So I'll kind of describe how we manage it here in the US. And then if you have any questions, please don't hesitate to let me know. So commonly here in the US, we've kind of moved where we're shining more light on it. It is becoming more known. And I attribute that a lot to the growth of social media and women talking to other women about these symptoms that can be very scary sometimes, very embarrassing, but there's just been a lot more dialogue happening. And then we as providers are working really hard to let people know that this is a diagnosis that is fixable. It does take time and it does take some work on your part. So a lot of times there's home programs and attending physical therapy appointments and sometimes seeing a pain specialist as well. So I'll go through kind of how diagnosis happens, and I'll talk about what it is. I've got my model here too. So vaginismus in the United States is commonly first diagnosed when a woman has difficulty maybe using a tampon for menstruation, or when they're having difficulty with penetration during sex, or maybe they're having difficulty tolerating a medical exam with the gynecologist. So oftentimes the front line is a gynecologist, the first person to hear about it. But I will say sometimes it's not on the radar and the gynecologist misses it. And so sometimes it comes down to the woman is seeing a physical therapist, maybe for some other symptoms, and then they start talking and it comes out that they're having these kinds of issues. So the care team often involves a gynecologist, sometimes a urogynecologist, and then a pelvic physical therapist, and then sometimes a pain specialist as well. But I know that you all are very well versed, but I want to cover the musculoskeletal implications of what vaginismus is so that when we talk about the treatment and the management, it makes a little more sense. So I've got my pelvic model here. Everything that you see in white is the bones. And then we have the first layer of pelvic floor on the bottom here. And the pelvic floor is muscles, just like everywhere else in the body. They can be too weak, they can be too strong, they can be too tight. And often in the case of vaginismus, what's happening is we have this superficial layer of pelvic floor muscles here that comes from the pubic bone, and then it spans out to where you sit, comes back around the anus here, and then the deep layer is supporting the pelvic organs. The deep layer is on the inside. With vaginismus, oftentimes what's happening is these pelvic floor muscles are clenching and they are too tight without the person being aware of it. So it's not something they're doing on purpose. Oftentimes it's a reflexive guarding mechanism But what that does is it makes it very, very difficult for penetration to occur at the vagina here. And so in this way, it becomes not just a musculoskeletal condition of the muscles, but also a coordination between the brain and the pelvic floor muscles. So when we're talking about management, particularly here in the United States, when they come to pelvic physical therapy, and pelvic physical therapy is usually frontline treatment for this condition, we're going to be taking a really thorough medical history. So we're going to be asking things about how often are you urinating? Is there pain with urination? How about bowel movements? Are you having constipation? And then we'll ask about any pregnancies, any back injuries, hip injuries. All of these things are related. And then we'll talk about how long the symptoms have been going on. And for some people, they're experiencing primary vaginismus, which means they've never been able to use a tampon or have a medical exam or have pain-free penetration, or maybe they were able to do it, but it was very difficult or very painful, versus secondary vaginismus, where maybe they were able to do those things or have pain-free penetration, and then something changed, something happened, and now they are no longer able to. Oftentimes, factors that drive vaginismus or lead to it can include having a surgery in the pelvic or abdominal region where there's some scar tissue or there's some pain and the muscles are kind of clenching and guarding as a result of that. Sometimes history of trauma or abuse, whether it was emotional abuse or physical abuse or sexual abuse, is a predictor for this, where the pelvic floor muscles are very, very tight. And then other issues may just be coordination issues where they had issues with potty training, and those carried through into adulthood as well. Certainly times of stressful events can cause us to clench up. So if there's been a period of stress in your life, this can happen as a result of that as well. And when we think about the role of the pelvic floor muscles, they are to support those pelvic organs and maintain continence, but they also happen to reflexively contract as a mechanism of guarding us. So if we've been under a circumstance that's stressful or traumatic or feels like a threat to us, they are going to clench down and guard us. So here in the United States, we try to take a lot of time to get to know our patient when we're gathering history, and then we do a thorough exam where we're looking at how their back moves, how their hips move. We measure their strength of all those muscles because they are related. And then we may do an internal vaginal exam on that first day, and we may defer it. For example, if there's a long history of trauma or abuse, we may look at deferring that examination while we're working on learning how to relax and breathe and gaining trust, because it's a very intense and very sensitive area. But we're not in a rush. We're not trying to push some sort of treatment strategy on our patient. We're looking at what works and what doesn't work. And as I mentioned, there's a lot of different types of modalities that we can use. And I always like to say there's 100 ways to wrap a Christmas present. So it's biofeedback is a modality where we put sensors, little electrodes around the vagina, or there is an internal vaginal sensor if the person can tolerate that. And it gives a screen feedback of what those muscles are doing. And here in the United States, we have some software that can give some really cute imagery to help someone learn. For example, if this is the pelvic floor and it's very tight and very closed, and we put the sensors on, the image displayed on the computer is a rose, like a flower, and it's closed. And then we're guiding the patient to be able to learn how to drop and relax and open the pelvic floor. And they get a visual feedback on their screen of the rose blooming down and out. So that's just one example of biofeedback. Now that might work for some people. It may not work for everyone. It's one avenue of treatment. But initially what we're working on is teaching them how to breathe properly. Interestingly enough, people with vaginismus and other pelvic pain syndromes tend to breathe really shallow in through their chest. They tend to have some rigidity in their trunk as well. And the other thing is that oftentimes there is a sense of stress surrounding this. So that can put someone into what we call like a fight or flight response, where they can get even more stressed. And especially when they're told to just relax, right? It's one of the worst things I think we can do as providers, is tell a patient that they just need to relax. At the end of the day, we are trying to teach them how to relax their pelvic floor muscles, but they don't know how. And so what we're trying to teach them is using visual imagery and using breathing to stay calm and expand their rib cage. What that actually does is it helps to mechanically drop the pelvic floor muscles. The diaphragm, where we breathe, and the pelvic floor work together like a piston. So when we inhale and the diaphragm drops, the pelvic floor also drops. So we're teaching them to breathe, not just for the sake of breath work, but also because it has an actual mechanical change on the pelvic floor muscles. So that's usually one of the first things that we're teaching them. And then we can be using different types of visual feedback, whether it's with mirrors or with the biofeedback, as I was just talking about. And then additionally, there may be some manual therapy that we're doing to help reduce scar tissue or any fascial or musculoskeletal restrictions around the vaginal opening, around the hips and in the abdomen, particularly if they have had a surgery or if they've had another injury to the area that is a component of this. And then we get into a home program. And usually with the home program, we're teaching them in the clinic, and then the expectation or the hope is that they are going to carry this on in between treatments at home. Typically, we see patients 1 to 2 times a week, and then the length of time they're in therapy is highly, highly variable. We may see someone once a week for 5 or 6 weeks, and then start decreasing that frequency with them while they're out working on things, or some people may be in once a week for months and months on end, and some people simply need to be taught how to relax the pelvic floor, and suddenly things open up, and it's a very quick treatment. All of those are normal. I always like to tell people that this is a process of changing the tissue, but it's also a process of learning a coordination of a muscle that you can't see. You probably weren't aware that it existed prior to coming in. So it's really important to give yourself grace and to have patience with yourself, and to accept that it may be several months process, but you're going to reach your goals, and it's all going to be for the good. So in that home program, dilators and wands are some tools that people can be using to help address their symptoms. I created a set of dilators and a wand that is meant to be helpful to reduce restriction in the pelvic floor. Dilators, there's a lot of different ones on the market. They start very, very small. They often come in sets. Ours come in a set of 8, for example. So as you can see, this one is about the size of my pinky. I'm getting ready to launch a new set that's even smaller, more the size of like a Q-tip. But the purpose of dilators is meant to help train the coordination in the brain and in the pelvic floor to work together, so it's more under control, and so that they're not clenching without you being aware, so that when the time comes to have intercourse or to have a medical exam, that your brain knows how to, on demand, drop and relax the pelvic floor. So when we're talking about dilator use, we are talking about still using a breathing pattern. I like to tell patients to do a breathing pattern of whatever feels comfortable, anywhere from 2 to 5 minutes prior to using their dilator. And for some patients, when they're first starting out, this is really scary, really intimidating. Sometimes culturally, there's just some taboo feelings around it. So I always try to assess where they are in that spectrum prior to initiating dilator use. For example, with somebody who's having a lot of difficulty and they're not going to be able to tolerate this, what we do is we start with the breathing and we start touching the dilator onto their forearm, onto their shoulder, onto their abdomen, and then maybe the inner thigh before it ever approaches the vagina. And what this does is it helps them to learn what it feels like. It helps them to sense it on their skin, and then they can use some self-talk, which sounds kind of silly, but it's really powerful and it really works. We call it a top-down approach when we're using self-talk to help us not go into that fight or flight response where the stress can increase. So an example of that might be, this is a dilator, it's a tool to help me. This is a dilator, it's not going to hurt me. It's here to help me, I'm going to reach my goals. They can even be more like a self-love type mantra. It's whatever works for that individual person and what they feel comfortable with. But what we're doing is working it towards the vaginal opening, because the intention is that we're gradually going to tolerate something cylindrical in the vagina in service of getting ready for penetrative intercourse with no issues, no pain, no blockages. So, for example, ours go up to very large. And for some people, that is not a goal that they need to achieve. For example, if you're working on being able to be with a partner and your partner is this big, then this is your goal, or maybe slightly above it. So there's no pressure to be able to, manage very, very large things if that's not something you're ever going to encounter. But what I recommend, this is the vaginal opening here, and they're preparing to be able to tolerate penetration, is that they bring it up to the opening here, plenty of lubrication, 1 to 2 tablespoons, so lots and lots, and bring it up to the opening here, maintaining the breathing and working towards being able to put the tip in, maintaining breathing, and if that's working, slowly but surely getting it all the way in. That may take 1 session, that may take 3 weeks. Again, it's really highly variable. People progress at very different consistencies, and the presence of trauma is going to oftentimes require more time. It just simply takes more time, and that's where having grace and patience is hard, but it's really important. Once you're able to tolerate having the entirety of the dilator in, then I like to recommend what I call the clock method. So if the vaginal opening is a clock, and the top is 12 o'clock and the bottom is 6 o'clock, we have 3 and 9 and all the numbers in between. Once it's in, you're gently going to compress down into 6 and release, and then over into 7 and release, and you're just working on the tissue around. So that's where we're working not just with the brain to be able to relax and expand to have the dilator in, but we're also working on the tissue as well, so that it's learning how to stretch and be mobile and flexible. And so you can be compressing and holding for 30 seconds and working your way around. I like to recommend what I call tomato touch, especially when you're first starting. So if you were going to check a tomato for ripeness, if you were going to be cooking with that tomato, you would gently squeeze the tomato, check it for ripeness, but you wouldn't press your thumb all the way through and squish your tomato. And that is the same level of pressure that we're always going to use, whether it's with a hand, a dilator, a wand, whatever. We're not pushing so hard that we drive pain up or that we irritate the tissue or cause it to spasm shut. We're being very, very gentle. And so once you're able to tolerate that, then you move up to the next size. You start the process over. And for some people, again, it may be a week just working on getting the tip in and moving it up. And for some, it's once they've learned how to drop and relax, it's very, very easy. Again, it just comes down to practice. So with the dilators, I recommend using them 10 to 15 minutes, 1 to 2 times a day. Take a day off, in between, like a Wednesday and a Sunday off, but just working on gradually going through that. And that's while you're in the process of pelvic physical therapy. And then for some people, they have tender points or knots within the pelvic floor. Again, they are muscles, just like everywhere else. You can see how they sweep and span up into the hips here. And just the same way you might get a knot in your neck or your shoulder and you push on it, it zings up and over your head and it's very, very painful. The same thing can happen in the pelvic floor, especially if they've been chronically clenched like this. And they can drive pain, and they can be a limiting factor to that flexibility. If you can imagine, if you've got a knot in your muscle, it's not expanding. And that's where we could be trying to teach someone to drop and relax, and the muscle is just simply not going because it can't. It's very, very rigid. And that's why I created the wand. So the wand is designed to be able to go either end. Can go within the vagina to be able to do really gentle mobility, sweeping into the pelvic floor muscles. And it can also pinpoint and do trigger point or tender point release into the pelvic floor muscles. Again, tomato touch. So we're never pushing any harder on those muscles than we would use to check a tomato for ripeness. And that's for the health and safety of the tissue. It's also because the tissue, the muscles will get irritated if you're too rough with them. And it's the same thing we notice with penetration. If you're coming in hard and not taking your time, they are going to clench and it's going to be harder. So we want to approach it very, very gently. So those are common components alongside doing gentle stretches. They mimic yoga often, where the goal and intention is to get some opening and relaxation of the pelvic floor muscles. And then given someone's individual needs, there may be additional exercises there for the back or the hips as well. If those certain treatments are not progressing somebody quick enough, or if they're having struggles, then we may also be consulting with a pelvic pain physician who does other forms of treatment. Those can include trigger point injections with a needle, Botox. So Botox being a chemical that acts as a paralytic, and they use very, very small amounts, and they can inject very specific muscles in the pelvic floor to cause them to release. They don't do it mass to the whole system here, but they will do some trigger point injections with Botox to help that particular muscle release, which can actually be really beneficial for some patients to be able to get in and do dilator work or do manual therapy within pelvic physical therapy as well. And then oftentimes we're also working in conjunction with some sort of counselor, especially if there's been a history of trauma or if they're just simply struggling. This is a huge strain on a relationship oftentimes. And so different forms of counselors can be really beneficial for stress management, pain resilience, and for also partnership struggles that can often sometimes work against what's happening in physical therapy. You know, if life is hard, it's really hard to focus and be able to do the work. And then we also like to encourage people to be physically active, going for a walk or finding something that brings you joy, whether it's dancing or Pilates or yoga or running or whatever it is, to help be getting good levels of endorphins, overall wellness, and then just the psychological benefit too of getting your heart rate up and getting some blood flow to the area as well. So that's kind of a high level look at what we do. Are there any questions about what I've said so far?
Not really, not yet, but just to reiterate very interesting points that you make. Again, Vaginismus in Indonesia is we're starting to recognize it. Me as a medical personnel as well, it's been challenging for some of my friends that I saw when they saw a case of vaginismus due to the stigma around it, and yeah, it's just interesting how you pointed out in a very anatomical, very physical way, as if it's a real medical condition that we need to recognize. A lot of it reminds me of muscle memories, how some of the trainings kind of train your muscle memories to relax, and then yeah, it just helps with the condition using the dilators and the wands itself. But one of the very interesting points as well is the biofeedbacks with the visual aid. I mean, it really helps totally. I mean, me as a medical personnel, I know the anatomy, but with the visual feedback, it really helps the patients to recognize what is wrong with their body, what is happening, and it just really helps. I think hopefully we can get some of those items here, but I reckon it will take some time to get some of these treatments in. Yeah, I'll give you some more time if you have anything to add, if you want to wrap up things before we continue to some of the questions that we already have from the audience.
Sure. Yeah, I love hearing your perspective as well. And one of the things that I like to highlight is 100% a very real medical phenomenon where the muscles are behaving in a way that the person is unaware of, they don't understand, and they feel so broken and they wonder what's wrong with me. And I like to liken it to handwriting. You know, when we are very young and we're learning to write our name, oftentimes, you know, if you can picture a little child and they're holding the pencil like this or like this, but they can see it and they're learning how to operate their hand, and it's a fine motor control. And when they write their name as a 5-year-old versus as an 18-year-old, that's very, very different. And that's fine motor control. It is honestly the exact same thing here, only way harder because they cannot see it. They don't know what's happening. And oftentimes they didn't even know there was muscles down here. And so it does, it's not going to take, you know, from a 5-year-old to an 8-year-old length of time to rectify it. But it is the same type of coordination and learning. And I think when we phrase it and think of it in that way, it causes them to relax a little bit. Like, okay, I'm going to learn how to operate these muscles. I do need to see it using either a handheld mirror or the biofeedback. And it is going to take a lot of practice to get it to be under my control and coordination. And it is a coordination issue. At the end of the day, it's like learning to ride a bicycle or all of those. It's a coordination issue. But the stress component and the trauma component is what makes it really hard for a lot of people. And that's where we pull in all those other resources, because managing the physical component goes much better when the heart and you know the whole person is involved, because you can't separate them. You just can't. And emotion is a big part of it. So yeah, the biofeedback is very fun. We also have like dolphins for little kids, because we have little, you know, not necessarily just for vaginismus, but for issues with having bowel movements and things. And they can play games and they can jump.
Wow. Yeah. Well, it's really mind-opening as well to me. I mean, I really love how you present the condition in this way. I mean, I really believe that it will help a lot of people in Indonesia to understand vaginismus a bit more, because it's always I mean, based on some clinical experience that I had, especially in rural Indonesia, they always just think it's a mind thing. It's because you're thinking of it that way. It's because of your mindset, because of the trauma, but we kind of forget the physical aspect. And as a physician, I feel ashamed now, because it's so obvious that it's very muscle related. It's very it's your pelvic floor muscles and everything, which would definitely help a lot of treatments in the future. So thank you very much for it. Okay,
you are so welcome.
I'm gonna switch back a bit to Indonesia.
Yeah.
Jadi tadi kita barusan saja mendengarkan paparan yang sangat jelas sekali dari Dr. Amanda Olson mengenai vaginismus itu apa. Beliau menjelaskan kalau vaginismus itu sebenarnya adalah otot-otot dasar pelvis kita itu kontraksi, tegang tanpa disadari. Jadi perlu disadari bahwa di bawah pelvis itu ada otot-otot, teman-teman. Nah, otot-otot itu tuh di beberapa orang mungkin susah dikontrol, atau tanpa kita sadari tidak terkontrol sehingga dia akan tegang. Nah, vaginismus itu dibagi dua, ada primary, ada secondary. Kalau primary itu bisa dari awal terjadi, secondary terjadi karena beberapa faktor-faktor, misalnya ada operasi, ada riwayat trauma, atau misalnya stres sebelumnya. Nah, kalau di Amerika nih, sekarang sudah lebih banyak tahu karena informasinya lebih banyak karena media sosial. Saya rasa di Indonesia juga sama seperti itu. Media sosial jadi sebuah mediator diskusi di mana perempuan bisa bercerita dengan perempuan lainnya. Kalau di Indonesia kita bisa lihat pejuang-pejuang vaginismus bersatu untuk bercerita, berbagi cerita sesama lain. Kalau misalnya sesama pejuang mungkin lebih enak ceritanya. Kadang ada yang protes juga tuh, banyak yang protes ke saya, dok, saya periksa ke dokter tapi dokternya nggak ngerti vaginismus, jadi diperiksa-periksainya nggak penting gitu, gimana nih gitu. Jadi mungkin lebih nyaman kalau antara perempuan dan perempuan cerita terlebih dahulu, sehingga waktu ke dokter mereka sudah punya informasi lebih, jadi lebih tertata lagi gimana nanti ketemu dokternya mintanya apa gitu. Yang modalitas tadi yang dibahas sangat menarik yang sudah digunakan di Amerika. Pertama ada biofeedback yang dapat menunjukkan bagaimana otot-otot itu bekerja. Dapat ditunjukkan juga melalui visual feedback. Maksudnya apa? Jadi otot-otot yang kontraksi itu direpresentasikan di layar dengan bunga. Misalnya kalau ototnya tegang, bunganya kuncup. Terus nanti kalau sudah belajar relaksasi, bunganya lama-lama mekar. Gitu. Jadi kita bisa melihat langsung juga ini otot-otot mana sih kira-kira yang tegang, otot-otot mana yang mesti direlaksasi. Kadang kan susah mungkin membayangkannya, semuanya terjadi begitu aja gitu. Tapi dengan ini kita bisa lihat lebih jelas sehingga kita bisa tahu mana yang perlu direlaksasikan gitu. Tadi Dr. Amanda juga sudah menjelaskan mengenai penggunaan dilator untuk melatih otot-otot, penggunaan wand untuk melatih otot-otot, terutama otot-otot di dasar pelvis. Jadi dengan menggunakan itu lama-lama kita membiasakan otot-otot kita untuk relaksasi sehingga waktu kita misalnya menggunakan tampon atau kita melakukan hubungan tidak tegang lagi dan itu mengurangi rasa sakit. Lalu tadi ada juga tambahan terapi yaitu trigger point injection. Itu menarik juga menggunakan botox untuk membantu relaksasi beberapa poin otot-otot di dasar pelvis itu sendiri. Tadi jangan lupa juga konseling karena terakhir Dr. Amanda juga mengatakan bahwa ada hubungan antara stres yang sangat kuat dan keadaan vaginismus itu sendiri. Jadi bukan cuma ototnya saja, tapi keadaan ini susah ditangani karena ada gabungan antara stresnya itu juga gitu. Jadi dua-duanya bisa ditangani menggunakan konseling untuk membicarakan masalah-masalah apa yang ada dan stres apa aja yang harus ditangani. Lalu meningkatkan kesehatan secara umum. Jadi teman-teman jangan lupa untuk tetap olahraga, meningkatkan endorfin yang dikeluarkan dari tubuh, meningkatkan heart rate dengan olahraga-olahraga ringan sehingga tubuh tetap sehat. Nah, itu dapat membantu juga nanti kita untuk mengontrol otot-otot kita, terutama yang ada di pelvis, sehingga dapat membantu menangani vaginismus itu sendiri. Nah, sekarang saya udah bicara banyak banget. Saya mau memberi kesempatan dulu kepada tamu kita satu lagi yang tak kalah menariknya untuk Mbak Amelia, pejuang vaginismus. Pasti sudah banyak juga yang mau ditanyakan. Daripada saya yang penasaran terus, saya kasih waktunya langsung ke Mbak Amelia. Please, Mbak Amelia.
Oke, terima kasih Dr. Mike. Bicara bahasa Indonesia dulu ya. Nama saya Amelia. Saya salah satu anggota dari Komunitas Pejuang Vaginismus, dan hari ini saya sudah mengumpulkan beberapa pertanyaan yang umum ditanyakan oleh teman-teman di grup Pejuang Vaginismus untuk disampaikan ke Dr. Olson. Untuk pertanyaannya akan saya sampaikan ke Dr. Olson dalam bahasa Inggris. Okay, hello Dr. Olson. I'm Amelia from Pejuang Vaginismus community. We are a support group for women who experience pain during sexual intercourse, especially the one caused by vaginismus. And in our group, the member will be able to share and discuss their condition without being judged. And tonight, we've been compiling the most common question we've received so far from our member. So, how do women in US handle their vaginismus condition? Are they open-minded to tell their family or friends about their condition?
That's a wonderful question. As I outlined, generally there is a combination of care in the US from a gynecologist or a urogynecologist with a pelvic floor physical therapist, and it's a team effort very much so in conjunction with the counseling and all of the treatments that I described. Again, keeping in mind there's no one size fits all. Something's going to work for some and not for others. And then regarding do they talk about it, I would say in the last 3 years, I've seen a lot more courage and a lot more discussion. I've seen social media accounts solely dedicated to vaginismus popping up where people are sharing their journeys, sharing what's working for them, a lot more groups like this. But I will say there is still a lot of shame surrounding it. There are still a lot of people that do not tell anybody. They are in treatment for it, but they're not discussing it openly with their families. I would say most people will share their condition with their partner. And maybe like a close girlfriend to have that support. But it's highly variable, especially given like a religious background. Their faith-centered inclinations can often drive their need to keep it quiet or to themselves versus others maybe are just very very vocal. There's one such account, I think it's called Overcoming Vaginismus. It's on Instagram, and she has documented her journey. She's very open with, what she's been through, and I really commend her, and as healthcare providers, we're trying to create a space where people can share, but I would say it's still highly variable, and it's still a very taboo kind of subject here in the US. So I'm seeing a lot more courage in the younger people, early 20s, but I'm in my late 30s, and I'd say my generation and beyond is still pretty quiet about it.
Okay, thank you, Doc. The next question, should patients continue dilating after they had full PIV, penis in vagina, the sexual intercourse, or they can, continue after the pain stops?
Really great question. I recommend that they use it at least one time a week just to help keep up with the maintenance of it, kind of like brushing your teeth. It's kind of just something you do. But for some people, once they really learn that drop and relax, they honestly don't need it. And for some people, especially around a period of stress, that the muscles may get a little tighter again, and they need to use the dilator. So I would say always have them on hand. 1 to 3 times a week as maintenance is a good window after you've been able to achieve pain-free penetration. It is highly variable, but I always warn people, if it comes back, if the muscles seem to clench again, don't worry. Do not fret. There's nothing wrong with you. This can happen around times of stress, even if it has nothing to do with your relationship or your condition. Those muscles can get tight again. And it's always easier the second time around, or doing kind of some of the starting it back up again with the daily use. It goes a lot quicker and a lot easier. And it's honestly very common. And so don't be surprised. Don't be upset. I know it's frustrating, but it's quite all right.
Okay, Doc, amazing. And then does any exercise that can help to cure vaginismus, or is Kegel the right exercise to help to cure vaginismus?
Great question. So Kegels are actually the opposite. We don't want to be doing Kegels with vaginismus. So when we think about the bowl here and how the pelvic floor muscles form that dome, what a Kegel is it's a contraction and a lift, which is honestly what the muscles are doing already. And so we actually don't want to be reinforcing that with the Kegel. What we want to be doing is dropping and relaxing. So it's this maneuver. A cue that I like to use with patients is to imagine, it's going to sound silly, I'm warning you, is to imagine that you're trying to make that rosebud bloom down and out, or that you're trying to blow a bubble out of the vagina. So you're getting this to happen with the pelvic floor. And so oftentimes going into that breathing, where you inhale and bear down and drop down, or almost like you were going to have a bowel movement, but it's always very slow and very controlled. And initially, when the muscles are very tight, it's very difficult, and you're not going to get a lot of range with it. But eventually, it's just like any other muscle. If your shoulder was tight and you were trying to stretch it, initially it's going to be very tight and not a lot of movement, and then you're going to start getting that nice bubbling, and it's the muscles just elongating. So no Kegels, opposite of a Kegel, drop and relax, where the muscles are opening. And oftentimes we have them practice that in a set of 10 with the breathing. So inhaling and dropping, imagining that bubble being blown down through the vagina. And then with that, a couple of stretches, you can see them on our website too. Happy Baby, which is a yoga exercise, child's pose, and a deep squat. All of those stretches naturally put the pelvic floor into a relaxed and open position. And so that's kind of part of the ongoing maintenance as well.
Okay, thank you, Doc. And then the last question from us, how to handle the pain during dilating? Is there any practical tips?
Yeah, absolutely. So starting with the breathing pattern and going so slow and not pushing through that pain barrier. So pain is so tricky because it is a very complex neuromuscular experience. on a scale of 0 to 10, where 0 is no pain at all and 10 is the emergency room, I always like to recommend that we never ever in one session go beyond a 2. So some discomfort, some stretching sensation, when you stretch your hamstring and it's like, okay, that's strong, I feel that, is okay. But we don't want to blow past that, because what is going to happen is those muscles are going to recoil almost like a rubber band, doing, and they will be more challenging to work with. It's actually worse. So for example, if you're in this stage where you're working here and this is a 2 out of 10, then we're going to stay here and we're not pushing, we're not blowing through that barrier. That is tissue and you can strain it just like everywhere else. So if the muscles are contracted and we're trying to force it, it would be the same thing as trying to force your hamstring. You can strain it. And that's not to scare you, it's just to say, we want to respect those boundaries here. So using plenty of lubricant, going really slow. So lubricant on the vagina, lubricant on the dilator, maintaining here, breathing. And you may find that if you're breathing here for about 3 minutes and you're in this position, the muscles relax a little bit and you're able to go a little bit more. And maybe it's just that much, and maybe it's here. So those are the top ones. And then also just expecting that every day might be a little different, and you're going to meet yourself where you are in that particular day, and you're not going to try and push it. So that's where that kind of grace and patience comes in.
Okay, thank you so much, Doctor, for answering our question. Maybe we can back to Dr. Mike.
Thank you very much, Mel, for all the questions. There are still a few more questions. I hope you're keen on answering some of it.
Sure.
So one of this question actually came from women without vaginismus. So she was reading about it on our sites, and she was asking whether she should be worried because she's not currently suffering from vaginismus, but will it come in the future, and whether she should be worried about it. Is there anything that he should be more careful about in terms of getting vaginismus in the future?
Sure. Generally, no. If they don't have symptoms, generally it won't occur. But as I mentioned, there is sometimes an occurrence of secondary vaginismus. Sometimes after having a baby, there's some scar tissue in there. I think growing awareness is good, but it's nothing to be afraid of. It's nothing to fear. It's one of those things that it's not just going to spontaneously happen out of nowhere, although it feels that way to the person sometimes. It's not really anything to be concerned about. But if she does start to notice those symptoms, then initiating care with gynecologists right away is always a good idea.
Awesome. Yeah. But I think she was reading about secondary vaginismus, and she was worried that because it might happen to everyone, it might happen to her as well. But thank you very much for it. So identifying it would be a key, I reckon.
Yes, it's a helpful statistic is roughly 1 in 7 women experience it. So I think that helps to give perspective of the women that are experiencing it are not alone. There's a lot of women that are experiencing it, but there's, the remaining 2 to 7% is not going to experience it in their life.
Right. Okay. I'll move on to the next one. So this questions come from someone who's been using a dilators. So she was asking whether dilator will make changes in the vaginal walls and make it a bit looser. Would that happen if we continuously use a dilator?
It would have to be excessive use for long periods of time, each day, every day, for a very, very long time. Eventually the tissue does change, but the vaginal tissue is very flexible. So what we're trying to incite is flexibility where there wasn't any for the people with vaginismus. So trying to get some recoil there. But in terms of denaturing it to the point where it's too loose, it would have to be used for probably about 2 hours a day, every day for several years on end. So excessive use that probably nobody has time for.
Okay. Next one is a bit more practical questions about the dilator. So do you need to boil it every time you want to use it to sterilize it first? And do you have to use regular bath soap, or is there any special soap that you need to use to clean it before you use it or after you use it?
Sure. Yeah, regular hand soap with warm water is enough. Just the same way as we, would wash our hands. It's the same way here. They don't need to be boiled. And in fact, like medical grade silicone like ours cannot be boiled. So yeah, just regular warm water and soap, and washing it prior to using it in that particular session, and then immediately after the session. There are certain kind of vaginal device washes available on the market, but they function just like a regular hand soap. So I always like to advise people to just use the regular hand soap that would kill bacteria on your hands.
Okay. Awesome. Yeah. Some of these very practical questions are quite tricky, especially for us doctors who are not really familiar about dilators.
Sure.
Yeah. Just another one, I think. This is a very this idealistic question. Is it important for women to understand their pelvic floor muscles? Considering that, especially here in Indonesia, there are not as many therapists or doctors who focus on treatment of the pelvic floor muscles, like as much as you do, at least. Yeah.
Absolutely. Yes. I think it is very important to understand your anatomy because of a few things. One, because we're learning how to use it. So understanding how it functions is really important. I think another thing too is that when we understand that at the root of it, it is muscles, tendons, ligaments, just like everywhere else. I think that knowing helps remove some of the fear, because it's like a black box in a way, almost like in an airplane, right? Where when we don't know what it is, that's very alarming and very scary. So once we take that away, it can almost relieve them to the point where treatment becomes significantly easier. So honestly, every single patient, I go through what I went through with you, where I show them, and I like, even here in the US, where people talk about their bodies probably a lot more. They want to see it and they want to like feel it, and sometimes they want to like experience like the density, and it's like a light bulb. It's honestly, as a provider, it's one of the most rewarding parts, I think, of that journey, is like just helping them to understand what their body looks like and what it is.
Yeah. I totally agree. As I've mentioned previously, I mean, it baffles me a bit, and it's just, it eases me to understand what vaginismus is, even as a doctor. I mean, it's practically just muscles, even though there's complex nuance around it with stress, trauma, and everything. But what we can kind of narrow it down to the condition that is just muscles, and I think it will help a lot of people outside when they're confused about the condition, and we can point it out that it's this piece of things that is causing this to happen. Amazing. Thank you very much, Dr. Amanda. I'll give you a bit of time for respite, for a break. I'll head down to Mbak Amel now. Terima kasih Mbak Amel sudah join kita malam ini. Tadi sudah bertanyakan beberapa pertanyaan. Sekarang gantian nih, kita minta Mbak Amel. Coba Mbak Amel, tadi sudah mendengar cerita dari Dr. Amanda. Kalau dibandingkan dengan Indonesia, kira-kira bagaimana nih perbedaan-perbedaan besarnya, atau berbagi cerita yang berkesan dari teman-teman di Indonesia yang kira-kira bisa terbantu oleh cerita-cerita Dr. Amanda barusan. Silakan Mbak Amel.
Oke, terima kasih dok. Tadi mendengarkan penjelasan dari Dr. Amanda itu sangat menarik sekali ya, membuka wawasan bahwa ternyata vaginismus itu memang adalah sebuah kondisi gangguan fisik gitu ya, pelvic floor muscle disorder, gangguan otot dasar panggul yang sebenarnya sangat bisa di treatment, diberikan perawatan, diberikan program penyembuhan yang baik dan layak gitu ya. Karena menurut pengalaman saya dan beberapa teman itu masih banyak baik dokter, baik tenaga kesehatan di Indonesia itu yang menganggap vaginismus itu murni karena psikisnya gitu, kayak mungkin menganggap vaginismus adalah salah satu gangguan mental gitu ya, ada something wrong with our mind gitu kan. Terus karena pengalaman saya sendiri, saya itu sebelumnya sudah tahu 6 bulan setelah menikah tuh kebetulan sudah tahu tentang vaginismus. Tapi kan tetap butuh diagnosa resmi ya dari dokter SPOG. Itu pas konsul memang langsung dapat diagnosa vaginismus, tapi diarahkannya ke psikiater gitu kan. Nggak ada itu namanya terapi dilatasi sebagaimana dokter Olson tadi jelaskan ya. Jadi cuma dikasih konseling saja, terus dikasih Xanax gitu, tapi nggak pengaruh sama sekali gitu kan. Nah jadinya yang awalnya saya cuek dengan vaginismus dan bisa berharap oh ya mungkin memang bisa terbantu dengan konseling kejiwaan, akhirnya mulai mikir oh ya mungkin memang ini butuh ada terapi fisiknya gitu kan, terapi dilatasinya. Nah karena kebetulan waktu itu dokter yang saya datangin nggak bisa bantu bantu terapi dilatasi, akhirnya saya modal nyari info nih di internet kan pakai bahasa Inggris, pain with penetrate pain during intercourse gitu kan, terus saya cari vaginismus, how to dilate gitu kan, how to choose your dilator gitu kan. Terus akhirnya saya memutuskan untuk beli dilator dari luar negeri, kemudian beli buku kesehatan terkait panggul itu dari luar negeri juga, dan kebetulan ada salah satu bukunya Dr. Olson juga yang judulnya Restoring the Pelvic Floor for Women. Itu cukup membantu ya, terapi alat dilator itu sama buku-buku kesehatan mengenai nyeri panggul gitu sangat membantu sekali. Dan akhirnya ya bisa saya sudah bisa berhubungan gitu, penetrasi dengan suami gitu, sehingga mungkin harapannya ke depannya ya Indonesia itu baik masyarakatnya, tenaga kesehatannya itu bisa memahami bahwa vaginismus itu nyata gitu kan, itu adalah sebuah kondisi gangguan fisik otot gitu, bukan tidak murni itu berasal dari pikiran kita gitu kan. Nyerinya itu bukan di kepala tapi di panggul, di pelvic floor muscle gitu. Memang bisa gitu kan, maksudnya ada terapi penunjangnya untuk konseling gitu kan, itu sebagian orang bisa terbantu untuk menurunkan anxiety-nya gitu kan, menurunkan stresnya. Tapi kan kalau misalkan tidak ada terapi fisik seperti terapi dilator itu kan progresnya gitu nggak maksimal, benar, iya. Tapi alhamdulillah sih saya lihat sekitar 3 tahun terakhir ini gitu ya, udah banyak dokter yang menggaungkan gitu ya tentang kondisi nyeri seksual, sudah mulai menjelaskan tentang vaginismus apa di media sosial mereka gitu kan. Terus dokter-dokter itu juga udah cerita vaginismus itu nyata loh, bukan cuman karena mental illness, bukan karena pasiennya punya maksudnya bukan murni trauma, tapi memang ada gangguan di otot dasar panggulnya, dan itu harus diberi treatment yang baik, diberi treatment yang layak gitu kan, diajari terapi dilatasi, nggak bisa dengan terapi konseling saja gitu kan, memang harus ada terapi dilatasinya. Nah itu alhamdulillah dengan adanya dokter-dokter yang sadar vaginismus, paham vaginismus gitu kan, sama yang mungkin visi misinya sama seperti Dr. Olson gitu kan, itu akhirnya selain menimbulkan kesadaran akan vaginismus, itu juga membuat orang-orang yang punya nyeri seksual itu jadi berani untuk ngomong. Kayak saya beberapa kali ngeliat di Twitter gitu ya, kayak nanya, aku nyeri kayak gini-gini gitu kan, di Twitter kadang suka ada akun yang khusus untuk perempuan gitu kan. Nah itu biasanya nanya-nanya di situ terkait gangguan seksual, terus jawabannya itu udah bener-bener yang enak banget, kayak kamu periksa ke dokter gitu kan, jangan-jangan vaginismus, jangan-jangan ada penyebab lainnya. Jadi orang-orang tuh sudah sadar gitu kalau sexual pain is real, terus memang harus segera diperiksakan ke dokter gitu. Dan orang-orang juga udah mulai bilang kayak dokter jangan mau, bukan nasehatin dokternya sih, maksudnya kayak nasehatin antar pasien untuk kayak komunikasiin kayak, dok, saya ini benar-benar ngerasain sakit gitu kan, maksudnya memberi pemahaman gitu kalau sakit saya ini nyata, mohon bantuannya. Dan kalaupun misalkan memang dokter yang kita datengin itu nggak bisa, kebetulan juga kan karena sudah banyak dokter yang ramah dan paham vaginismus ya di Indonesia, alhamdulillah, itu biasanya teman-teman akan mulai banyak nih yang rekomendasiin, dokter A nih bagus nih, dokter B nih bagus, kayak gitu. Jadi bener beberapa tahun ini udah mulai ini sih ya, sexual education-nya di Indonesia sudah mulai bagus ya. Harapan kedepannya sih bisa lebih baik lagi ya dalam sexual education-nya dan untuk penyembuhan vaginismusnya gitu.
Wow, oke, mantap banget ceritanya Mbak Amel. Setuju banget, setuju banget. Sebenarnya saya pernah ngadepin yang menarik tuh, saya pernah ngadepin sebenarnya kasus vaginismus.
Oh, siap.
Bukan saya sebenarnya, tapi teman saya. Jadi kita waktu itu ada penempatan di daerah. Dia menceritakan kalau ada perempuan datang baru sudah menikah selama 6 bulan, tapi setiap kali penetrasi sakit, dicurigai sama keluarganya kan, masa perawan terus gitu, apa gimana, apa kenapa. Terus habis itu ya udah disuruhnya udah relax aja, waktu hubungan relax gitu-gitu. Tapi sekarang setelah mendengar cerita ini, setelah baca-baca tentang vaginismus, baru tahu tuh, waduh ternyata waktu itu sebenarnya sarannya tuh bisa lebih mendalam lagi gitu. Bahkan sarannya itu jadinya kayak kesannya nggak dokter banget, masa kesannya cuma relax aja, udah pikiran santai gitu kan, bukan itu ya. Ada pelatihan otot panggulnya, ada latihan otot pelvisnya. Ya, harapannya sih semoga dengan meningkatnya waktu, edukasi mengenai seks meningkat, cerita-cerita dari teman-teman pejuang vaginismus juga makin banyak terekspos, melek lah semua orang, dokter juga melek akan ini. Karena kasihan, pasti terapi yang pertama nih ya, tebakan saya ya, kalau misalnya ada yang keluhan kayak gitu, terapi pertamanya apa? Pasti masukin spekulum. Udah deh, kita coba pakai spekulum dulu. Nah itu kan ya malah tambah tidak nyaman kan, itu malah tidak membantu gitu. Tapi untung Mbak Amel mantap banget, masih mau mencari informasi sendiri. Nggak apa-apa, itu justru malah kayak kalau saya dapat pasien seperti itu malah wah benar nih berarti saya yang kurang belajar gitu. Jadi bisa introspeksi diri, dan semoga dengan itu bisa menambah pengetahuan kita semua nantinya. Terima kasih banyak Mbak Amel, ceritanya mantap banget sih. Mantap banget.
Sama-sama dok, terima
Tetap
kasih.
Semangat dan tetap berbagi ya ke teman-temannya yang lain dan ke dokter-dokter juga kalau bisa. Siap.
Siap dok, terima kasih banyak.
Dr. Amanda, I'm just gonna give you a brief summary of what Amelia just said to me. So she told me the stories about her struggles with vaginismus, and how at the beginning it was really hard to find treatments for it. So she started looking on the internet, started looking on how to use the dilator by herself, which she just takes the initiative to do so, and she bumps into one of your books as well, which she mentioned helped her a lot in dealing with the vaginismus. But she also mentioned that during the past 3 years, she saw that a lot of doctors are more knowledgeable towards the condition. Some have realized that this is not just, as I've mentioned as well to her, that we only thought that this is a psyche thing, it's a mental thing. What you need to do is just relax. You don't need to stress it out and everything. But we kind of forget that there's also physical components to it. Your pelvic muscle floors contracting involuntarily. So she mentioned that a lot of doctors start to realize about that as well, and they start to incorporate both the psyche and the physical treatment into one to help vaginismus treatment. We're a bit, I reckon we're a bit behind from US, but we're getting there. Hopefully, we're getting there definitely. Yeah,
that's awesome. Yeah, it's growth, and it's awareness, and the more we know, the better we do, and it's an ongoing process. And who knows, what treatment techniques we'll have available to us in 5-10 years. So I'm so amazed at Amelia's tenacity to go out and learn. And I think a lot of people do that in the US too, is they self-manage and they self-educate and they become an advocate, and then that spills over so that other people don't have to suffer anymore.
Yep, that's what I was mentioning to her. It's just amazing to hear her stories, the tenacity that she had to find treatment. Yep, anyway, we've talked a lot about vaginismus. Thank you very much, both Amelia and Dr. Amanda. Before we close this show, I was just going to ask Dr. Amanda if you have any last word, any last message you want us to hear to all the vaginismus warriors in Indonesia and to all the women in Indonesia as well. Please, Dr. Amanda.
Absolutely. I guess I would just say that keep advocating for yourself, keep learning, keep looking for new avenues, find a wonderful practitioner like Dr. Michael, who's going to listen to you and who's going to help connect you with other providers. And it's a process, and it does take time. We always want to be better right away, but it is a process of finding what works best for you. And I'm always available. My website has hundreds of different videos and blog articles there, and then on social media as well. I try to create educational content that's helpful. So I would say stick with it, keep doing all the wonderful things that you're doing of showing up for yourself and helping advocate for yourself, and you'll get there.
Awesome. Thank you very much, Dr. Amanda. Oke, jadi sudah 1 jam kita bahas bersama terkait vaginismus. Semoga semua informasi ini bermanfaat untuk sobat sehat semuanya. Ingat untuk tetap jaga kondisi dan patuhi protokol kesehatan dan hentikan stigma terhadap penderita vaginismus. Mohon maaf jika ada salah kata-kata dari saya pamit undur diri dan nantikan kelas sehat Dr. Mike selanjutnya dengan topik yang tidak kalah serunya. Sampai jumpa semua, terima kasih.